because you're being recorded. We do still try to upload these to the YouTube just for people who don't get a chance to see them later. And as always, got to turn that transcription off before I pull a Ron Burgundy. So good morning, everybody. Welcome to 2024. Thank you all for being here today. We're going to go through our monthly meeting. Just going to do the classic welcome call review, our room for improvements, some metrics, IT updates, and then just some programmatic stuff that we're working on our side. Just want to say welcome. I know it's been a couple months since we all got together. I appreciate the amazing attendance here today. I kind of wanted to tell you where the email invite came from this time. So I think the old list had probably gotten a little bit old and tired. We pulled all of the admins from the STARS database, and that's how we generated this meeting list starting this year. So some takeaways from that. First of all, thank you for being the champions and the admins for your accounts. But also, if there's other people you want to include, you can add them, or if they're just a viewer on your account and you want to switch them to an admin, or vice versa, if somebody's receiving it who doesn't need to or want to be on these meetings. That's just kind of where we're going to pull the meeting list from, just to keep it a little more consistent with kind of who's invited. I'm fine with viewers and other people attending too, but that was just a good starting spot with the super users and stars. So just email me if you need me to make edits from there. We are going to do a brief call review this morning. Just saw a lot of good documentation in this one and thought some things worth pointing out. So this is a call that has happened since our last meeting there in November, but we are a couple months old on it. You can see the family did call in the evening, which is, a pleasant deviation from our usual 3 in-the-morning phone calls. And this was for a trach kiddo and a trach kiddo who was traveling. They were not in their usual area, and ended up getting into some distress actually immediately after a doctor's visit. That's actually not that uncommon of a story that we see, right? See the families down here for their visits, and then there's kind of that fragile transportation period, and they ran into some problems with the ventilator. As always, for my device-dependent medically complex kiddos, not only are we troubleshooting a patient, but we're troubleshooting equipment as well. And you can see that they ran into some power problems with their vent. They thought they could just fix it by getting some more juice to the ventilator, but then noticed that the kiddo was really struggling and in some distress. And as always, the family's already doing their thing. They have instructions and algorithms that they're following, very similar to ours. And so I kind of, even though you run to a scene, sometimes joining these calls is almost more like a transfer. Like you're jumping in the middle of some care that somebody's already doing. And so this crew did a pretty good job of kind of assessing where the kiddo was. You can see, did note some respiratory distress. They noted the accessory muscle usage. It's good documentation. I'm sure lots of people look for it, but not everybody writes that level of detail. And then they documented what they did to kind of address the distress. I also appreciate things we always ask, putting in title on trach patients for transport. And they noted that they not only put the end title on for the respiratory distress, but also just diagnostic, how is this kiddo doing? We love to see that. And then they did provide some inline suctioning to the kiddo, including documenting they attempted to titrate their oxygen back down after they were mid-treatment, but then did a really good job of saying he was fine for a little bit, and then he started to get sick again or in distress again, and they bumped right back up. So I thought really pretty good detail for the care that they did, and it was a really well written trach vent trip sheet, and so I was appreciative for this crew. And then you can see through their vital signs, the improvement that did happen. We were pretty tacky to begin with and desatting, and then you can see improvement with some care, and then towards the end of the call, we're up to 98% on our oxygen source. So just overall well documented, a really well run call. To juxtapose with that, I thought there's a room for improvement one we could talk about here just a little bit. This is a star that's pretty well known to us here at Glennon. And he was initially a ground response, and then they activated a helicopter for flight. So you can see we're more respiratory distress. my complex kiddos get sick with the same diseases all the other normies get. And so it seems like there had been some respiratory illness running throughout the home. He was desatting some. Home health nurse had attempted to treat with some bump in oxygen and a little bit of albuterol, but with no significant improvement. And then you can see they found him wheezing. This is all the HIMSS documentation from the flight crew. So even by the time they arrived there, about 20 minutes after 911, still wheezing. Um, Vital signs, nothing out of control crazy here. Satin pretty well. Not really documenting any respiratory distress. Oh, whoops, sorry, I left names in and tried to block those out. So we'll skip past this. But they ended up flying and went approximately a 58-mile flight to a hospital. And you say, Nick, that looks like a pretty tame trip. Not even necessarily 100% sure why a helicopter's involved. Why are we talking about this call today? So we went to an outside facility with the initial delivery. And this is the transport team taking the kid, transporting them approximately 2 hours later for the additional 30 or 40 minutes they needed to finish getting to tertiary care. So you can see he was brought all the way to St. Louis this time, and then was admitted for 1 week for his acute hypoxia from his respiratory failure. So let's see. So just some thoughts. As always, I know I have the privilege of reading trip sheets months later, and I get to Monday morning quarterback you guys, and that's not always fair. Um, there are reasons to go to outside facilities. But a lot of times once you're dealing with a kid who's pretty medically complex, and especially from past history, we know often goes all the way to their tertiary care. Um, I think that once you've activated a helicopter for the flight, the reasons to ditch closer are related to the helicopter and not patient care, right? Like, so if you run into weather or your pilot's going to time out, you do what you got to do. But if that was the case, there was no documentation in this run review to kind of elaborate on that. And so, as always, you can kind of see what happened here. We stopped at an outside facility. The patient received one IV. He got 20 cc's of fluid. The IV extravasated, and then they were unable to give antibiotics. They called another team to come get him, and he was flown by air again to St. Louis. So I think, looking back at it, there's probably ways where we can maybe get that first flight just to be directly to where it needs to go and save a kid extra hours of not being treated, and extra flight times and helicopters and risks to crews and all the stuff that comes with extra, possibly unnecessary, or should I say redundant flights. One other thing that stood out to me about the call, where a lot of the in-home care upon later review after the kid was admitted here, it kind of all started with a broken suction unit in the house, and family and home health nurse had stopped being able to suction the kiddo. So I know there's a few people on here where we're starting to talk about trialing and looking at what MIH looks for, and I couldn't help but notice that this is, potentially an example of with just a little bit of extra care and follow up and the ability to follow up, what can be avoided sometimes. So I certainly will take any feedback or thoughts if anybody has anything on that, but just one that kind of stood out to me.
Hey Nick,
Yeah.
Can you give some tips and tricks for advocating? As a ground provider, calling in the air resource. Hey, that hospital is reasonably close, but they need to go to the big children's place. What can we do to really sell that and advocate for the patient to go to the right place first time?
That's a really great question. And anybody who's currently from flight can correct me if I'm wrong. A lot of times as the flight crew, when I was flying, we weren't necessarily allowed to determine. Now I know we have some persuasive skills and the ability to kind of guide that conversation, but it's a lot of times it was meant to be, where did the family want to go first? Where did the patient want to go first? In the case of adults, where did the family want to go? And if they were unable to provide it, it was actually the ground crew who kind of helped dictate, where the patient should go, with some input from the flight team, right? Like we can say it's this many miles to here, this amount of time to there. So in some ways, I would argue you really should have the power in the conversation to say like, hey, this is my patient, I'm giving them to you. This is the center where they receive their care. I certainly don't mind, especially in the case of stars, if you drop the stars name all over it. I hope my children's people feel the same, but I assume they do. Like, just, hey, this kid is in this program and they need to get to the providers who know them. That's the whole point of this. And so I feel like that's a way you can advocate for it. Always have to have a slightly open ear if they're giving you a legitimate reason why they can't. But I think a lot of times it's just information like this, even the ability to illustrate outside of the emergency, but just say like, hey, it's, you know, where this kid isn't going to stop at that outside facility. We need to get them to where they need to go. And that's the whole point. You're using time critical diagnosis transport methods. And so did you have some more on that, Doc Laffey?
Just, kind of our general, take on it. These kids are going to end up at Glennon or Children's around here, or, they're good, that we all know that the chance of them going to a community, if they're at all sick, the chance of them going to a community hospital and being sent home from there is super, super, super low. So we know where they're going to end up. And then the question comes, what are we going to gain at the outside hospital? And this is just another example of, and again, this isn't a knock on those hospitals at all. But they are generally, what happens is they go to the outside hospital, spend a lot of time there and get very little intervention. So having that knowledge, I think is hopefully is empowering. We can do what they're going to do. We know where they're going to end up. It's cut out the middleman, get them to where we, like I said, we know that that's where they're going to go. I agree with Nick in this one. And there could be something that we are not aware of that wasn't documented. But once this kid's in a helicopter with that crew, who's clearly able to provide, let's face facts, just about every single thing that the community hospital and more probably, then just hustle them on down to the big house right on the first round. If that's what you're asking, I think if that was kind of what the gist of your question was.
Yeah, and I kind of appreciated this call because I think it even highlights it more, because there is always this like, well, he's not that sick. Maybe we could just go outside, and just to highlight, like, he was sad and just fine and a tiny bit of distress. But like, I mean, most of us wouldn't get too bent out of shape if this kid presented to themselves right now on a call with us. And just to highlight like that, even that is, he wasn't kept in an outside facility. It was immediately within a couple hours, hey, we are shipping him out. And so that's just kind of a really common trend we see. And so a way to advocate for your patient, just to say like, hey, we know this isn't a normal ped. He's got a lot of history. We know where he's going to go. Let's just get him to where he goes. So I hope that helps.
Yeah. And he spent 8 days in the hospital. It'd be one thing if he came and took a look at him and sent him home. And that does happen on occasion, but really our threshold to admit these, in fact, a kid like this, the chance of him going home would be 0. There's no way you send him that far away. We're going to watch this kid for a little bit. So, but yeah, this kid was in the hospital for 8 days. So it wasn't nothing.
So I did, for the most part, we pulled together all of 2023 stats. So just to look at what a whole year looks like from some of that STARS data that we do track. So just have seen continued growth both here in our region and with our Florida partners down at Golisano. The numbers, as some of you might note from your email accounts, especially if you're in closer to the urban core here, are only continue to go up pretty significantly. From our last meeting, we have added 96 kids. So between early November and now, 96 new plans, and just continue to see increased system use across the board. So you can see 41 dispatches via the website for January, pretty substantial climb over last year. So kind of interested to trend this and see where we're going. But I think, as you guys all know, our numbers will just continue to go up. Same for emergency activations. Transport calls total for 23, there were 361 911 calls that we're aware of. And the primary no surprise to anybody who's attended any of my meetings. 117 respiratory distress, 101 seizures, and then just a couple others rounding out the top 10 list. For non-transport calls, we had a pretty significant number. I think it was right around 60. And primary reason to no one's surprise there is seizures. And I think appropriately so, we're even for some of our status prone kids, what we're kind of seeing, those are the kids where family has instructions and it says, hey, kid sees this 5 minutes, or sometimes we don't even wait that long for the kids who we know are really going to take off and seize. Family is given a benzo pretty quick. By the time they're given their second dose, they're calling you. But the whole thing the family's trying to do is get it under control so they don't have to come to the hospital. And sometimes they do succeed and just want a little bit of monitoring. I read a number of pretty good trip sheets on this front. The one thing I will kind of advocate for is just a really good spaced set of vital signs if you're going to do a refusal on that, especially if you get there and they're still seizing and or pretty postictal, but they're coming out of it. I saw just a couple trip sheets where it was like set of vital signs, he stopped seizing, 5 minutes later, set of vital signs, and we got a refusal. And it seems to me that if you were there and you had a tried and true medical emergency in front of you, or very recently in front of you, just make sure that just for your own protection, you're really getting that good documentation in of this kid was really trending the right way as we were going to leave this scene, and left the kid with parents. So.
Hey, Nick.
Yep.
Just what I always say to folks in the ER, kind of a similar thing is, if we're not gonna do anything for any particular kid, let's say it's a kid with a fever and I'm not going to do much. Well, what if something bad happens? What if he comes back and he's sick? What if we miss something? Your documentation should make it clear that anybody in your situation would have done the same thing. It's like, well, yeah, I understand he got worse, or I understand he seized again, we had to go back, but look at my documentation. Clearly, any reasonable person would have thought it was perfectly fine to let this kid stay at home. And that's really what you want to be doing. You want to make it clear that anyone who reads your notes, like, well, of course you didn't take him. He was doing X, Y, Z, whatever you're documenting. So that's the way I would look at it, is if something untoward were to happen, if it turns out you maybe in hindsight, maybe should have grabbed him, just make it clear in your documentation that it was why, not just why you didn't, but anyone would have been happy to leave him here.
Yep. Absolutely. Sorry, I was just checking the chat here. Gotcha. Ms. Crystal, yeah. So, where that statement came from. So, these two data metrics, and just for anybody who hasn't heard this before. So we do track a lot of what happens within the STARS website. It's just a way for us to try and understand, when emergencies are happening and how the system's being used. And so a couple of different ways, as you know, from your dispatch center, you have the ability to log into the website and dispatch a plan. Whenever you go to get into any kid's plan in your area, if you're doing it for an emergency, that prompt comes up that says, are you accessing this plan for an emergency? If you are, click yes for a 911 call or for patient care. If you're just doing training or review or something like that, just click no for us if you don't mind. But all that does is build reports in the background for us of system use and how it's being used. And so this is what we use to try to figure out where 911 calls are happening. This combined with Epic for transports, where my team, Morella, goes in and looks and says, hey, which STARS kids came to the ED? And so we'll try to kind of look backwards on that. The only reason I say that we know of is because different agencies use STARS in lots of different ways. I still have some far away from us who only have one kid in the county, and they're going to use a piece of paper and a binder. And, I understand if that's what you got to do to make it work in your area. Will always hazard you, the fallibility of pieces of paper and binders. But, to a certain extent, I understand you got to do with what works in your area. But as we see more and more kids added to areas and build up, I think it makes a lot more sense with the electronic system. And these are just all tools we use to try and say, track down like, hey, when are emergencies happening? So I hope that helped answer that. And I'm happy to stay on and talk more about it at the end. Did see, so for the entire year, MDO approvals, about 5 days to complete. So we'll keep working away at that. I guess I got to get a gold medal in the mail for Miss Angie, who got 197 plans in last year, followed by Miss Jamie with the silver at 158. And I'm just lagging, and I'm going to tell you I'm probably going to get really busted this year. So, oh, and yes, Dr. Cookies, you are on the slide. That's awesome. And then just our attendance awards. This is daily unique logins. So shout out to my dispatch centers, and Collinsville is going to get the gold medal on this one for 361 out of 365. That's pretty good work. So congratulations to you guys, and thanks for your diligence, all my dispatch centers, and logging in and being prepared to use the system. So I appreciate it. Just wanted to briefly touch on IT updates. You guys probably all noticed, especially in January, some increased communication coming to us when we're doing website updates. That's our goal, just to be, more transparent and make sure you guys are aware when we're changing things in the system, especially if it's going to impact end users. So just kind of expect we don't do a lot of updates, maybe monthly or bi-monthly, at most. So just kind of know that we're communicating that with you just to let you know when the system will be going through some changes. And also because, in IT updates and tech updates, that is the moment in time where things can become a little more precarious. So don't hesitate to reach out to us, at our IHT email, or any of us. If something doesn't seem right with the website, please call or email, and we'll get it fixed up. That is how we find the problems. So couple people have brought up to me, this is an oldie but goodie slide with sometimes security changing on your email accounts at your districts, and it blocking emails from stars. We are actually working on fixing that by switching the way we send out emails, but it's going to take a little while to convert the whole system. So these are just some different addresses that your security team can allow, that will make sure that the emails are flowing through to your users. So happy to share that in a better format after this if you guys want. I did want to briefly touch on STARS inclusion criteria, just because this has come up in a few meetings we've been in lately of people kind of asking us, why, when are you guys going to put the kiddos with autism in, and some questions like that. And so I just kind of want to, we've been working on refining our list, but our system's a little bit different in that it's fewer kids, and the kids who require a lot of follow-up and intense follow-up. And so our system is always going to be a little more defined, and kind of have a smaller inclusion criteria. Systems like that are certainly coming, and I look forward to them as much as you guys do. We will gladly do the training and education to support good care for those patients, but we just aren't able to enroll every child with special health care needs in STARS. We're really focused on the children with medical complexity, and so I hope this list helps, but also it's not incumbent on you to know our criteria. So if you're receiving referrals from your community, you can always push those towards us at STARS referral. Even if it's a children's kid, I can pass it to Miss Jamie. She's very very good at answering really quickly on those. So like I mentioned, we will do the education even on non-STAR stuff. So, we have a course up online for the Autism for First Responders. We're happy to come out and teach on respiratory distress in kids, seizures, even for the normies. A common request we've been getting a lot this year is for NRP. And I just want to have this conversation, since you guys are a group of pediatric champions and super users. It's really hard to get NRP out there, right? Like, it's hard to find instructors for it, and to maintain the certificate, to get the certification, and then to maintain the certification. So if you need it for the certification, unfortunately, I don't have a lot of good recommendations for you, but we do have a class aimed at just knowing, mom's in trouble, kids are in trouble, and what do we do about that, particularly for the pre-hospital. And I think this course is actually almost better than NRP, because we don't have all the lamps and all the saran wrap and all the fancy tools that come with some of that other stuff. And so, yeah, saran wrap's hard to find, but you get the gist. And so we're happy to kind of continue working on this and coming out and providing it. we're going to trial a few different ways to do that this spring, but I want you guys to have the info, and we certainly support that, even in a non-star setting. It's just, I did want to kind of address just to a large group, the NRP challenge. That is, unfortunately, I don't know how to overcome it because I'm a medic and they won't let me be an NRP instructor. No sour grapes or anything. So, Todd Claffey, you got something?
So we were just talking about this at PALS last week. One of the things, just background to the conversation, all our neonate NICU nurses are now going through PALS, which has been really interesting. We were kind of talking about NRP and that, and there used to be in PALS, there used to be a bigger component of neonatal resuscitation. We used to have lectures and scenarios that involve that. And I'll tell you that there were very few neonatologists or people from the nursery that I wanted teaching that station or giving that lecture, because you don't want a neonatologist telling you how to resuscitate a baby in the living room or the back of your rig or the bathroom of the target. It's not the same thing. And they would, you can go to NRP and you'll spend, the amount of information that you're going to get is insane. The amount that's germane to what you're going to need to do is just not that much. So if you need it for some reason, I would say my first thought is that's unfortunate. You shouldn't need to do NRP. What you should need is some of the basics of what to do to resuscitate a baby. And to be honest with you, the vast majority of it is keep them warm and give them oxygen and check their sugar. That's 99% of it. That'd be my take on NRP. Is, to be honest with you, I don't think it's the right thing to learn for a pre-hospital situation. But I think there should be a fairly easy way to provide the proper information of what you really do need to learn without doing NRP. That's just my take on it.
And I appreciate Stephanie, both for the NRP course. But yeah, I think we're kind of all of the same mind of what we need to know in the field, at least. For anybody in the Southeast Missouri region, we're going to be out there this week, so you probably are already aware of the EMS refresher. Terry might or might not be giving the trauma and pediatrics, to be determined. And then, but would be happy to see any of you guys pop out there if you're available for some training. Or if you need to reach out to us and contact us, I'm happy to work on providing training at the district. We're getting everything back on track in this office, and we're getting out a whole lot more. We're kind of scheduling out through April and May already, so happy to come teach wherever you guys need us. I did want to give a shout out to our EMSC colleagues. They're putting on the first annual Missouri conference, EMSC conference, and so they still have some open registrations as far as I know. Danny can correct me if I'm wrong. She's smiling, so we assume we're good. And so pre-hospital will be March 5th and 6th, and hospital will actually be 6th and 7th. And just, for all the champions, and I presume if you're in this meeting, you're on that list of pediatric champions in the pre-hospital and hospital world. This is just an opportunity for a free conference to touch base and learn about how we're going to put this together in our state and continue improving the standards of care for the kiddos. So, Danny Lee, is that good enough, or did you need anything to add?
Thanks, Nick. Yeah,
Okay.
Please attend. There'll be a lot of people to network with and learn about like-minded individuals that care about pediatrics and EMS. So,
Danny, can you post a link? I can't find it in my email.
who was that? I was talking. Yes,
Stephanie.
I will. Yes, I will.
Very sadly, I will not be there, but a lot of really great people I know will. So
that conference is at Margaritaville too, guys. It's
Terry, that is
Thank
hardly
you, Terry.
important.
What
just
would I do?
saying that's important.
Yes.
Awesome. So I took us the full 30 minutes. A little bit atypical for me, but happy to hang on here if anybody has any questions or anything here in the chat. If you got to run to the next meeting, thank you so much for your time today, and I'll look forward to seeing you next time. So cool.
Couple questions, Nick.
Yep.
Is that conference virtual at all? It's way
It's-
too cold for me to go to Missouri.
It's not virtual, but we are going to try our best to record all of the sessions that we can, and really strive to make it virtual in the next 2 years.
Okay. And then Nick, do you have any updates on